Michigan. So a very, I use the word straightforward Facebook Live. This nice patient, 53 years of age, presents with a set of implants that she got in 2003, back in the day when saline implants were allowed. Silicone implants you could only get unless you were part of a study or you had them for reconstruction purposes. So she comes in with the many symptoms of breast implant illness. Just the fact alone her implants are from 2003 in itself alone is a reason to be removing. So she basically did her homework and did a lot of research up from state of Washington. And as you will see, 100% total capsulectomy, 12, 16, 25, initials NG. And you can see this is the excess skin that I removed to help with the contouring. And you can see the ultra thin capsule tissue. And so I'm overall very happy and content with how the whole dissection has gone. Complete, total, 100% capsule removal below the muscle. The only one implant that she has had. And you know, you will see right here, a lot of things to learn. No matter how thin the capsule, the entire implant has to be removed. So if I place this underneath, you can see how thin this capsular tissue is. No matter how thin, it has to go. You cannot tell by looking at it what it is and what it is not. So in my practice, complete total capsulectomy is always the rule, be it en bloc fashion or 100% total capsulectomy. So now I'm going to peel this off. Saline implant is what she has, and you will see right here there is some fluid in the back. So if I take this, look at this leaching of the silicone. This is your McGann 360, and on the card it said 390, so they overfilled it by 30 cc's, and so it's certainly overfilled. And again, you will see the crunchiness, and as you will see, look at that yellow fat behind. I've incorporated that as well because it felt abnormal, looked abnormal, palpated abnormal. Remember, it's not only about the implant, but the capsule plus that inflamed tissue around that's also implicated in the underlying problem. So as you will see, complete removal of the capsule implant, and then I'm very happy and content how the whole dissection has gone. Minimal blood loss, probably like 3 cc's if you ask me, on the right side. I'm going to remove my top sterile glove, and so you have the excess skin. The distance from the nipple down to the crease, 5.2 centimeters on the right, 5.2 centimeters. So as you can see, I cut more skin here to balance the two out. Now this is something that's very important. In my practice, I do not cut around the nipple areola up and down. And whatever is above the pectoralis major muscle is the breast tissue is not touched at all. And I'll say this again. If this is the nipple areola, breast tissue, you have the muscle, and then the implant, and then the ribs. So I'm always in this P2 category below the pectoralis. The P1 category where the implant, where the breast tissue is and not the implant is not touched at all. So the P1 category is where you have the breast tissue. I do not touch it. That's why I can operate on patients who are actively nursing. Below the muscle is where the implant is in this case, as is in majority of the cases. That's where I am as I dissect, so I do not go into the breast tissue area at all. And I do not want to distort the mammogram, and I do not want to distort the self-monthly breast exams, and this certainly preserves the aesthetics. The second thing, I put a dot right at the nipple, and then measure the distance down to the crease on the right. In this case, it was 5.2 centimeters, and on the left, 5.2 centimeters, so it basically balances itself out. So more skin, as you can see on the left side, so as to balance the two sides. And again, you can see how thin the capsular tissue is. I'm very happy and content. Again, you will see how thin the capsule is, along with all inflamed tissue that has been removed. And as I dissect, you will see the crunchiness. Remember, if you ask me, this is not, I use the word normal human tissue, this crunchiness. And I am going to cut this open. So you can hear this crispy capsule. And again, some of the fluid in the back. Look at that. That's the leaching of the silicone from the silicone shell of the saline implant. And this is also supposed to be 390 cc's filled according to the card which the patient found, and 360 cc's. A patient very well read. She, as you can see, very thin capsule in here, and even if I try to tear it, you can see how thick it is, and it does not belong in the human body, just grossly looking at it. And so all of this capsular tissue, that yellow fatty tissue, has been removed, and the entirety of all inflamed tissue, even anything questionable, has been removed. And remember, anything below the muscle is the implant capsule, so there is no excess volume that's removed. The breast tissue, again, has not been touched. So the implants will be returned to the patient, capsules to be sent to pathology, rule out the rare BIA, LCL, CD30 analysis, rule out breast cancer, rule out BIA, SCC, anything abnormal. Remember, the pathologist is the one who's going to do the CD30 stain. I'm going to take cultures for aerobic, anaerobic, and fungal. Patient is in twilight deep sedation. No need for the unnecessary lift. No need for the unnecessary drain. And this patient got the same surgery that any patient does last week's 83-year-old patient 2 weeks ago, the 36-year-old patient. Everyone deserves that same world-class i.e. removal of the implant capsule, so that when we look back at this case afterwards, we could not have done it any better. We could not have it any complete and any more comprehensive, because we're giving it the best shot. Minimal blood loss, less than 3 cc's on each side, and I couldn't be happier with how the whole surgery went. This is Dr. Khan, Executive Plastic Surgery.